plume of gas that came into the vessel. The vessel actually dilated. You know how long that process lasts? 10 seconds. 10 seconds. So this is not some chronic phenomenon that's going on. But think of it this way. Nitric oxide is the Mother Nature's way of blunting vasoconstriction. And as you heard, and correctly so, that if you eat a lot of salt, you're gonna get vasoconstriction because of a lot of neurohormonal changes, and the kidney can't get rid of it fast enough. So just keep that in mind when you're thinking about nitric oxide. This is not some chronic effect. It's a preventing an acute effect. Now, let me ask a question. Let me make a statement. Based on what Christy said, and Aaron, what you said, I would make the following assertion. There's overwhelming evidence that lowering LDL to limits below 70 is going to reduce cardiovascular risk. I don't think anyone's arguing that point. But I would further say, with a focus on triglycerides, because I've been following this from a distance. From what you said, I think it's very clear that if you want to reduce triglycerides, you're going to prevent pancreatitis if it's high enough, but also you may not necessarily reduce cardiovascular risk, but you are, if you dose it appropriately and you get the right levels, reduce stroke, and there's some evidence, small, post hoc, you may reduce sudden death. Would you agree, disagree? What do you think? Pick up the mic. It should be on this one.
Yeah, so again, it's how you reduce triglycerides and what your goal is. So I emphasize the importance of lifestyle. So the lifestyle changes that we talked about that lower triglyceride levels have multiple effects that can lower, stroke and heart disease risk and lower cancer risk, and because there's so much benefit from a healthy lifestyle and a healthy diet. And then the omega-3 fatty acids, lower MACE, they seem to lower MI risk more than they lower stroke, although it reduced, icosapent ethyl did reduce stroke, but that wasn't seen in the VITALS study where omega-3 reduced MI and not stroke. But there's some controversies how so we've tried therapies like fibrates to lower triglycerides, and adding that to statins, that strategy has not been shown to reduce MACE. And so that's where I think that triglycerides themselves may not necessarily be the primary target of the risk as a treatment target, but they're a marker of higher risk patients. So if you have a patient with elevated triglycerides, this is a patient with elevated ASCVD risk. So you want a multi-pronged approach. You want to get their LDL way down. You want to have them make sure their blood pressure is controlled and their glucose is controlled and they're exercising. So I really see it as an opportunity. This is a flag, and this is a high-risk patient that needs further preventive efforts.
Chrissy, you want to say anything to that, or agree with above?
I agree with the points of the
Yes, go ahead.
Aaron discussed why we might not see consistent changes in CVD risk with omega-3s, and you covered some really good data that a lot of us didn't know about, particularly the blood levels of EPA. I think it was 170 in the placebo trial. There's two other things I'd like to ask Christy about, and that relates to the potential oxidative stress of omega-3 fatty acids, both in the capsule, breaking down, but also in the cell membrane. If they're not balanced with the correct amount of tocopherols, which is one of the major reasons that omega-3s are balanced with oxidative stress. That's one issue. The other is, in most of the trials that were done, a lot of them didn't have pre and post measurements of anything with omega-3s, and we don't even know what they really use, because if you go back and look at the methods, they don't even tell you the quality of the omega-3. So we don't even know, half the stuff you said was full of saturated fats and other things. So I think those two things, in addition to what you said, could be very valid reasons for why the data is all over the place.
That's a good point. So we worked a lot with the initial formulation that was approved in the United States, which is a mixture of EPA, DHA, and that does include some vitamin E as an antioxidant. but it is something, this is one of the things that trusted me, is if you look at this is one of the things, what's sold in the health food, basically, if you go to a pharmacy, those are supplements. They're not over-the-counter products. There's a different, when you buy ibuprofen has it's an over-the-counter product from what was previously an FDA-approved agent, and there's certain manufacturing criteria that have to be done. Some of these formulations may be pretty good, or they may not be good. This is where there's huge amount of just varieties of that. That's what's shown in here. Some of them have saturated fat. The other ones, if you get cold water fish, you might actually get some mercury in there. There's other things. Where it's coming from. So this is the issue of the quality of the product, as you mentioned. So a lot of the trials use the same formulation. It started with the GISI study. There was one company that was Omnivore, which was also used a lot of it. It's a pretty high quality product, but it was 1 gram a day. And it was in a mixture of EPA, DHA, so the total amount of EPA, DHA was quite low in that study. So that this isn't one of the things that comes up, and there was no adjustment by either the baseline of the individual, or, for example, did they respond? So, we've never actually done a trial to get people to a certain level, which might make more sense.
So, Christy,
if it is the level of it.
That every single, your point, I just really want to make a big deal out of it. Every single drug that we use for blood pressure, 100%, had to go through a phase 3 dose finding study that looked at side effects and dose. These agents clearly, especially with the data on blood levels, clearly, I would say, have to be looked at. You've wasted millions of dollars on clinical trials just because you picked a gram. Where'd you get that?
So and this, one of the things that's really held back, there's been a tremendous amount of interest in vascular pathology, endothelial function. What's happening to the vessel wall? And unfortunately, this has been very hard to implement, because what's been done is it's difficult to do the dose response studies, George. So this was the problem. It's hard to quantitatively measure what's happening in the vessel wall. So we've seen lots of great ideas fail from really programs which may actually have been successful if they could have had easier. There were very novel approaches, but someone picked a dose and they did 4,000 people, and it didn't work. Well, maybe it was the wrong dose. So this is the issue with blood pressure, where you have a surrogate. I do have a question for you, George. We've got so much data, if you look at the epidemiology about blood pressure and genetics now, and yet in practice, there's this whole issue that came out with this Sprint study about lower blood pressures being better. I don't see it happening much in practice, and it's something that we looked at in the Eric study. Since you the figure out this paper, but if you look at the trajectory over a lifetime, we're able to basically, LDL may be high, but now we can just knock it down. And what happens is, as people get older, yes, we add more medicines, we lower systolic blood pressure, we lower diastolic blood pressure, but we start very late in life, and what ends up happening is the pulse pressure just keeps going up. So the arterial stiffness, we have not improved very well. And that's the thing, we're so fixated on looking at, and I'm guilty as anyone, looking at both systolic or diastolic, but we don't look at the pulse pressure. And what ends up happening is the pulse pressure tells you a lot about the health of the artery. And, my question is but not everybody goes up the same way. If we started earlier, is this where the lifestyle part, George? How do we end up impacting the pulse pressure more? Because it's discouraging when I look at the data, is that we really, the two things that we haven't done a good job with, we were able to lower LDL, we lowered triglycerides, those trajectories are better. Pulse pressure, we didn't do well with obesity either in the ERG study.
So, wow, okay. there's a lot of meat in there, so I need to kind of dissect it out and answer the question. First of all, I'm convinced that collagen degradation is a genetic phenomenon. So I have patients with hypertension most of their life in their 70s, and their pulse pressure is appropriate for their age, 70. I have other age people who have had hypertension that's been well controlled but have pulse pressures of 90. There's no question in my mind it's genetic. Now, that's number one. To your second point, since you brought up sprint, which to me kind of is the flag for the bull, those people did not study high pulse pressure. They studied a subgroup, and they published a paper because I basically said you have to do this or forget it. No one's going to believe it. What was the lowest diastolic pressure in the trial? 62. Those are not the 50s that pop into my office. So I think there is one trial that has been done, NIH trial published in 1991, the SHEP trial, the systolic hypertension, the elderly program. Everybody had to have a diastolic below 90 to get into that trial, and a systolic above 140. What did they determine in that trial? And it was, like, as I recall, it was around 4,000 patients. And it was an outcome trial. And what I recall from that study is the following. Number one, if you got the pressure down, systolic, below 140, you reduced mortality. No surprise. The surprise is the secondary analysis that they did. What if you couldn't? Because a lot of these patients that Christy's talking about, they can't tolerate it. Their memory goes bad, they're sleeping all day if you get it down. So what's your fallback? If you can get the systolic below 160, you also reduce mortality. Not as much as the 140, but as Christy originally pointed out correctly, these people are at higher cardiovascular risk just because of that. So what we've done, and I can't give you 15 trials, but we've gone to mean arterial pressure, because mean arterial pressure is what we used to use back in the day in the 90s when we did trials. We didn't use systolic and diastolic. And with mean arterial pressures, as long as your mean arterial pressure is below 98, and I picked that number because in the renal trials, if you were below 98, that was considered a lower number, and that translates roughly to about 130 over 80 if you want to do it that way. But remember now, this could be 140 over 60. But if you're at that level or below, patients mentate well, and they seem to do well, all right? Can I defend that with outcomes? No. But nobody's gonna take medicine if they don't feel well, as was pointed out earlier correctly. And so you wanna get them as low as you can. And the other thing is, by the way, and I've got two cardiologists here, you want to avoid, like the plague, getting diastolics into the low 40s. Because if you do that, the heart does not appreciate that when on diastolic filling, and there have been cases of sudden death. So you want to just be very careful about how low the diastolic goes. So just keep those points in mind. My answer to your question ultimately is, it's genetic, and keep an eye out for it. And when you're treating, I use the SHEP data, and that's the only good data that you've got. And this notion about getting everybody down to 120, I want to make a final comment. The editor of JACC, Journal of the American College of Cardiology, called me up and said, look, I want you to write a paper comparing European and American guidelines. And, you know, so I did that. Here's the if. You want to believe the trials? That's fine. You got to reproduce the trials in your practice, which means you better spend an extra 5 minutes with actually it turns out to be an extra 15 minutes measuring blood pressure correctly. Now, no matter what, you better measure blood pressure correctly, because that is your methodology. If that's screwed up, what happens after that is screwed. You'll be wrong. And that's why a lot of people have side effects from medicine, because they got white coat hypertension and you missed it, okay? So there's a very methodical way to go about doing this. And you do need to follow the guidelines there. Now, if people have good arteries, they don't have pulse pressures of 100, and that you've measured blood 5 minutes quietly, you get 3 readings, you average the last 2, everything is fine, there's no evidence of white coat, and you start treating, then yeah, less than 120 is a good place to be. By the way, as you'll hear this afternoon, there is no evidence anywhere that going below 130 gives you any benefit to the kidney. All right? And the benefit that you're getting being below 120 compared to being below 130 is minuscule. Yeah, a couple of percentages. And the cardiologists make a big deal out of it. I don't think so. Patients are not willing to take an extra pill just to get down there. And if they're at 125, I'm happy as can be. And so are they. So I think there has to be some judgment here. All right? That's my comment.
May I?
Please.
Arterial elasticity is a difficult problem in the clinic to treat because I really think, and George, you can tell me what you've seen in your practice as well, there is a spectrum of arterial elasticity issues. And I think some of them are reversible. Some of them are not. Some of them are strong, they have had it, what's the etiology, what's their genetics. But you can now measure this very accurately with a lot of different non-invasive machines. You can get arterial elasticity compliance, and J-Cone is a great machine for that called HDI. We have augmentation index. All these things really help you to get a handle on, can I do something to really modify the vascular biology, improve elasticity beyond just what I'm doing to the blood pressure? And we all get the blood pressure issues, and the study I mentioned earlier, you pointed out, the last study, just came out a few weeks ago, was a diastolic of 53 relates to bad news, and so you just don't want to go there. But it's really hard to keep the diastolic over 53 when you've got somebody with a systolic of 180 because you drop that one, and everything goes down on the diastolic side. But the people who have any reversibility in their arterial elasticity, if they're not too far gone, you can do it, but you have to do a lot of things. Sodium, I think, is one of the absolute necessities because those arteries are going to stay stiff until you get the sodium out. So there are all kinds of natural things in it. The content, you've got amiloride, you've got spironolactone, you've got Farxiga, and all the SCL2 inhibitors. So we can now get the sodium content out of arteries and out of the heart. I think that's one of the major reasons these drugs are effective, not only for blood pressure, but also for reducing cardiovascular risk.
So this, I guess my thought on this though is that if we look at healthy aging, so we're in this conference, and right next door they've got the anti-aging conference. But in regards to healthy aging, it looks at this issue of stiffening of the artery. We take a look at it's atherosclerosis and arteriosclerosis. It is nephrosclerosis in the kidney. It is hepatic fibrosis. Okay? Well, you know, isn't there? So all of these are fibro. I mean, if we look at this, so this process, this is where, you know, this issue of the diet and the exercise, and the individual with obesity, insulin resistance, hyperglycemia, glycation of proteins, there is a process that's taking place, and it seems to me, just like in lipids, it's dramatic. It's, first of all, measuring LDL is a lot easier than blood pressure. And then we have therapies that can knock it way down. But, you know, I think if you can start earlier, you can kind of, we can obliterate LDL as a risk factor. The other ones, lifestyle, I think, is going to be absolutely more important. The exercise, starting earlier on, does a lot of good things for arterial function, with it, particularly endothelial function with it. But I do think that if we were to, you know, basically treating people when they're 55 years old and they say, oh, well, you know, it's been borderline blood pressure and it's been running, you know, in the 140s for 20 years, and finally decide to start a medication with it, and that's because they also have A1C of 6.3, and they've been there for 2 decades or something. I do think we're doing things very late in both with lifestyle and with medications. Now, there's not a lot of evidence, as you point out, that we could change all of this. It certainly makes sense, though, if we look at the whole process of fibrosis and waiting until very late in life. You know, once you have structural changes, it's hard to do a whole lot.
So what you're talking about, and so this is a concept we haven't talked about, but you are talking about it, is for blood pressure, time and range. And so, you know, if you're cooking around at 140, and you can say, well, that's not so bad and all that, well, I got news for you. You've got injury going on, even at that level. I want to just give you an anecdote here because there's not a lot of data published on this. In fact, there's very little data. But it's been reported by the news. There is an island in Greece, and since Christy's half Greek, I figure I can take the liberty. But the bottom line is that this island, and it's called Ikaria. So what does that mean? That's the island of Icarus. So you all know Icarus. This island is got the longest longevity in the world. The mean age is like 95. What is the secret? Because it gets back to what Christy's talking about. They're essentially vegetarian. They don't eat red meat, truckloads of fish, a lot of fruits and vegetables, nuts, and they're physically active. Believe it or not, and I don't know what the percentage is, but yes, they do smoke. All right, they're Greek, so they're going to have to smoke. I mean, that's kind of a must. But I think the point, the take-home message is that if you're doing this from the time that you're growing up, obesity is minimal. So the American Diabetes Association wanted me to talk about the pathophysiology of diabetes and cardiorenal disease, and they wanted to know what's really going on. My first slide was the world and the trends in obesity over the last 20 years. There's your enemy, and fast food places and the lifestyle. And so if you want to change a lot of this stuff, then that's really where you got to go if you want to do it with what Christy's talking about. And he's right, that is what you got to do. But you have to, and I can't remember who said it. I think Aaron said it, and Christy may have said it as well. And actually, I think we all said it. Mark said it. You need to, if you see a patient that's coming in and you're not sure they're borderline hypertensive or their lipids are a little elevated, but you're not thinking. You shoot. You do it. You get them on therapy, and then you can backtrack. That's what I did with these people that I told you about that were salt hogs. I started them on therapy, and then I slowly put them on a low salt diet, and they themselves took themselves off the medicine because they saw their pressures are going down. You do that, you worry about patient adherence, you'll have 100% patient adherence after that because they will believe you. So it's important to get them involved in what you're doing in it so they understand why.
You know, the Greeks do have a partial corner on this market of hypertension, but there are also other populations that you know about. Some of the Paleolithic tribes in South America, the Maasai, they don't get hypertension when they get older. And for similar reasons, they don't get fat.
Right.
So the 120 over 80, 100 get over 70 from 16 to 90, whatever they live to. All is the same.
I want to ask Christine a question. You know, I would say 99.7% of my patients, when I ask them, what is your knowledge about low sodium diet? Well, just don't add any. I said, well, what else? Well, that's it, don't add any. They don't go to the dietitian, they're not seen by the dietitian, they're not given education. The physician doesn't have time and usually doesn't know enough to give them that level of education. So, what do you tell the patients when you see them in terms of the salt message?
Yeah, so I think that's a great point because often we think, just tell a patient not to add salt at the table. Salt added at the table or in cooking is a very small percentage of daily intake. Somewhere in the order of 5 to 10%. Most people know not to add salt. So what we typically tell people is to try and avoid processed foods. So processed foods are the key source, okay? So any of I guess we're calling them ultra-processed foods now, so all the snack foods, very high in sodium. Actually, the number one source of sodium in the US diet is bread. So if somebody's eating a lot of bread, get them to reduce the amount of bread that they're eating. There's unfortunately no low sodium breads on the market. And bread needs sodium for the texture. Low sodium bread is very dense. It's not particularly nice. But within the bread range, there are lower options. So trying to get somebody who's picking something, you know, around 300 milligrams would be better than one that's 1,000 milligrams. So just trying to, you know, work with them to identify some lower sources, but also getting them to think about where they're getting their food from. You know, restaurants, takeout tend to add a lot more sodium to foods than we would if we're cooking at home. So get them to think about where they're getting their foods from. And also, somebody mentioned it earlier, potassium. So, you know, potassium in some sense does counteract the effect of sodium. So even so, the US diet is so high in sodium and it can be hard to shift the needle because processed foods are so full of sodium. If we can boost the potassium intake, we're gonna improve that ratio. So potassium is found mostly in fruits and vegetables. So trying to get people to have a lot more fruits and vegetables is important. And I think that the final point is, you know, not to assume patients know what a healthy diet is. I saw some data recently from Ethic, and they said 20% of patients know what the dietary guidelines are. So the dietary guidelines are, you know, just general health promotion. USDA, you know, does some outreach. So if patients don't know what the dietary guidelines are, they're not going to know what, you know, a diet is to manage hypertension or dyslipidemia. So I think, you know, just planting the seed, even if you just have, you know, a minute or something, just plant the seed that lifestyle is important, and then try and, you know, refer them on or give them some information where they can access some more information.
So let me emphasize a couple of these points. One of the patients that I told you about that I had that was referred to me on 3 meds, and I got her off everything on a low sodium diet. She told me that she cooked with no salt. She was adamant she didn't use any salt. But oh, by the way, she eats out 4 nights a week. So we did a 24-hour urinary sodium, and it was 10 grams. So nothing serious, 10 grams. So she had no clue. We sat down and explained everything, and then when she got on a 2-gram sodium diet and we remeasured it, that's when her blood pressure medicines melted away. So I think it's very important. Now the point about potassium, I have to say, as a nephrologist, absolutely correct, and absolutely you should be doing this if you have normal kidney function. But if you've got people that have GFRs in the 40s, you could get into trouble with these high potassium diets. So you have to be careful then. But in the face of a GFR of 60 or higher, absolutely you should be following this. And I want to get back, Mark made a point about magnesium. Magnesium is just as important as potassium, and nuts have truckloads of magnesium. So I think it's important to just keep that in mind. By the way, nuts also have a lot of fat, so you don't want to overdo the nuts in terms of your weight. So you have to balance all this.
And when you're measuring these things, you have to know what you're measuring and how to do it. Because if you see a serum potassium in my clinical at 4, I'm concerned. I think it's probably not normal. But magnesium is a whole new story. You cannot look at serum levels and have any idea of storage. So you've got to get something like a red cell magnesium to really determine intracellular magnesium levels to replace it.
Yeah, that is also very important and also difficult to do. So none of you have any questions? Oh, here we are, yes.
In clinical practice, some of the most difficult hypertensive patients are stage 4 CKD patients and also dialysis patients. How would you put your pharmaceutical approach to those?
Okay, so the question in the back, in case you haven't heard it, is in the span of resistant hypertension, there are the most difficult patients are those with stage 4 CKD, GFR below 30, or dialysis patients. So those, believe it or not, are quite different. My approach to stage 4 CKD is to make sure that they're on maximal tolerated doses of ACEs or ARBs that won't interfere with potassium. So usually I use an ARB over an ACE inhibitor, and the reason I do that is because you get more blood pressure lowering, and head-to-head studies that have looked at this, and some, not all ARBs, but specifically really only 3, olmesartan, azilsartan, and to a lesser extent telmisartan. So I use those in maximal doses as long as the potassium is okay. I use a CCB and usually nifedipine over amlodipine. Why? Because you get more blood pressure reduction with nifedipine by about 3 millimeters, head-to-head comparison. And I'll use chlorthalidone or indapamide, either one of those. In fact, chlorthalidone has now been shown to be highly effective down to GFRs of 18. Now, I would argue, and dapamide probably is too, but the data is with chlorthalidone that was just published in New England. So, and it's long-acting chlorthalidone, 44-hour half-life. So I will use that in that setting, and then the next drug I'll go to, if I can, is spironolactone. Okay? Now, if you can't, what do? I go to a beta blocker. And I'll use, especially if the heart rate's in the 70s and 80s, and I'll usually use carvedilol because that's got the best data in those types of patients. And then after that, it depends on what's going on. I use a lot of vitamin M, known to use minoxidil, and I'll usually start at 2.5 BID and go up if I need to. But again, in those patients, what did we just talk about? Diet, 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 huge. Volume, because they're gonna have volume issues. If chlorthalidone, if they've got edema and they've got them on chlorthalidone, then I'll use torsemide as a loop diuretic. Why torsemide? Because it's longer acting. And you can get by with once a day. So that's the approach there. Dialysis patients, forget about pharmacology. Volume, 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 volume. First thing I do when I'm consulting a dialysis patient is I do a physical exam and see how much edema they've got, and they go on the machine and they get ultra-filtered. And once I've got them down to their dry weight, then we can talk about medications. And in dialysis patients, it's very different. RAS blockers are worthless. No point in using them. CCBs are king. Beta blockers are king. Blood pressure problems in dialysis patients is sympathetically driven. So beta blockers have to be on board there. That goes against all the guidelines we've written. But that's the subset where you really need to use them. And don't forget, the most common causes of death in dialysis patients are two: sudden death from arrhythmia and heart failure. So you really need to, and the heart failure because of volume overload. So diuretics don't really work. They really don't. I mean, if they're in the very beginning, maybe a little bit, but they're not going to do much. So you really need to think about other agents, and pretty much you can use Spiro. You can. If the patient's adherent, to the diet, you can do it. I've done it. It's rare, but you can. So, and there's a benefit. But
Instead of Spiro, what about Corindia?
so Corindia, I see. So you asked the principal investigator the question. All right. So we have not studied that in dialysis patients. Can you use Corindia? Okay. So I'm going to tell you right now, off label, because we haven't published it yet, but it's gone out. Corindia is advertised as it doesn't lower blood pressure, and it's magical, anti-inflammatory, and all that. Well, guess what? It does lower blood pressure if your pressure is elevated. It's kind of a smart drug. So if you're giving it to somebody at 150, 160, you will get a very nice blood pressure reduction. If you're giving it to somebody at 135, you'll get 2 millimeters. You won't get much. Interestingly, give Spiro to somebody with a blood pressure of 120, 125. Why would you do that? The dermatologists do it all the time to prevent hair loss. And guess what? I can tell you for a fact, full disclosure, my wife takes Spiro, 100 milligrams a day. Her pressure's 120. Never had a hypotensive episode. These are smart drugs. If Algo's around, you'll get an effect. If Algo's not playing a role, you'll get nothing.
You know, I live in the Dallas area. I see a lot of nephrologists and other doctors using hydralazine in these phase 4. Where is that coming from?
Well, all right, let me take a deep breath before I answer that question. There's nothing wrong with hydralazine if you were trained in the 70s and 80s. And if you're black and you have heart failure, it's fine. But people don't know how to use it. They're using like BID doses. Hydralazine is a QID drug. So anything less than 3 times a day, you can forget it, you're doing nothing. And unless if you're using at least 50, if you use, I see 25 being used, that's nothing. You're not doing anything with that. They think it's got less edema than amlodipine. For God's sakes, it saves sodium. It's sodium retentive. And it increases sympathetic tone. So a brief review of pharmacology is in order there, I think. Plus, the other thing that's not appreciated is the nitrates that are given from the original trial. You get nitrates with hydralazine, and that's it. But there's another reason to give nitrates, and then the reason is when hydralazine is metabolized, the peroxynitrite that's generated actually is vascular toxic. It only lasts seconds. But if you give nitrates, it sops it right up. So there's a theoretical reason to give nitrates along with that. Not that they're lowering blood pressure very much. I don't know, do you want to say anything about that, Mark?
The only thing I was gonna add is, I'm sure you do an SGLT inhibitors in your.
So I have SGLT2 inhibitors in the
That was
drinking.
another.
Well, that's in the drinking water. If you have diabetes, you're on an SGLT2 inhibitor. If you have IgA nephropathy, you're on an SGLT2 inhibitor because that's where the solid data exists. Now, do SGLT2s lower blood pressure? And the answer is, well, slow down, slow down. They would never make it at the FDA as an antihypertensive. They lower blood pressure on average 3 millimeters. Okay? What's the mechanism? And
Insulin
you're going to
resistance.
hear, well, they dump sodium because they're dumping glucose. And if your GFR is 80, that's true. Okay, how come when your GFR is 25, you're getting 3 and 4 millimeter reductions? They ain't dumping no sodium. So what's the mechanism? There's a fascinating paper in a journal I know you haven't read, because I didn't read it. It only came to my attention because I got it to review. JACC Basic and Translational. So this is basic science, medicine, animal studies and what have you, but have a translational base. So a friend of mine in Australia did this very elegant study. He took rats, 3 groups. He had a normal group, he had a group that he denervated chemically, and then he had a group on dapagliflozin. And what he showed was that the denervated rat and the rat on dapagliflozin were identical. He looked at tyrosine hydroxylase for synthesis of norepinephrine in the kidney, both dramatically reduced. He looked at renin, he looked at norepinephrine, he looked at everything. They were carbon copy. You could literally superimpose them. So somehow this drug, this class, is denervating the kidney in part because it's a sympathetic effect. It's fascinating. It's fascinating. So, you know, SGLT2s are big. You're going to hear this afternoon, I'm not going to scoop myself, you'll hear more this afternoon, but I think it's important to understand that SGLT2s, if you've got heart failure, or you have any level of kidney disease, GFR below 60, you really should be in an SGLT2, irrespective of albuminuria. That's a big deal. That's a big deal, and I think the cardiologists from the panel would agree. See, well, I'm getting resounding agreement here. Overwhelming consensus. Anything else? Yes.
Yeah.
Now, you stood up, so you get priority. You burn more ATP to ask the question.
Yeah, gotta stretch. So I'm thinking about a younger population here, myself, right? Low
about 60. Oh, no, go ahead.
So low ESR, testosterone is great, low CRP. My lipid fractionation is a bit elevated, right? My ApoB is a little bit elevated. I'm wondering how significant really is this for someone who's metabolically healthy, fasting insulin is like 2.5, no insulin resistance, large muscle mass. What do I have to worry about, 50 years down the road if I stay like this?
Well, first question I'd ask you is how old are your parents? Because you gotta look at genetics there in terms of longevity. But I'm gonna have Christy answer that question. From my standpoint, you get go forth and have fun. But I would see what the cardiologist
So
says.
family history is important. Lipoprotein little a. Did you get that checked?
It's normal,
It's normal. How old are you? Over 40?
29.
I'm not. So no, I'm saying that in just what we look at basically for calcium scoring
0.
is that, well, at age 29, it's a useless test. Okay. Pretty much, unless you have FH and you're trying to use, are they high or very high risk? So, this is we don't have simple tests right now. You can do you can do a cardiac ultrasound and look at IMT and plaque. It's probably going to be normal. That just be reassurance with it. You mentioned about some vascular reactivity studies sometimes with it. So where we lack a good test, very early changes of atherosclerosis are difficult to detect. The problem with ultrasound is it's so operator dependent. 3D ultrasound, Fuster's done some work where if you do 3D in the carotids and the femorals, he did a little bit better for sensitivity picking up in younger people with it. But it's a great question with it right now. And it's easier if someone's later in life with it. That depends how high is the LD or the ApoB. Because it's like, that's why they put in Scott Grunion going back, if it's over 190, So that's a high percentile LDL. I just feel like that's gonna be the area under the curve lifetime-wise is gonna be so high, it's worth just starting something. And B is the same thing, it's very high ApoB. But it's a big challenge because, you know, the intensity of therapy is dependent upon the overall risk. And then all of your other risks are low. Just having one thing up a little bit doesn't really put you in much of a risk category.
Did you say was your ApoB?
ApoB, yeah.
Did you did an expanded lipid?
I did a expanded lipid panel.
What was your particle number?
The particle number was about, 1,700, 1,800. It's pretty,
That's high.
yeah,
That's high.
yeah.
What about your, so it's small?
The small,
70, I mean, you should be, at your age, you'd be below 1,000.
no,
Mostly.
it was higher.
So here's what I would do. You're 29. You're not likely to get structural disease at 29 in your vascular system, but you're very likely to get functional disease. And it's based on your LDLP and your ApoB. So I would measure some arterial studies. I would do the arterial elasticity, C1, C2 compliance. I check your augmentation index, other things that you may not even know because you probably haven't had them done. And then I would stratify you. Yeah, your functional tests are abnormal at 29, so you may need to have that LDLP lowered to keep you from getting problems later. And then you look at your genetics. We talked about that yesterday. Do the cardiovascular genetics and see where you are, if you're ApoC3 or SCARV1 or something else, because you'll miss that totally by measuring HDL because you're not going to pick it up.
So easy genetics. Look at your parents, and if your parents are in their 60s or 70s, see if they've got a big pulse pressure of 70, 80. If they do, I'm sorry. If they don't, there's hope. Okay? Yes?
So the polygenic risk scores also, so in terms of genetic testing, that might be something to also use to give an idea. It's more with your family history. And if though they work pretty well for European ancestry, they don't work necessarily well for everybody.
Yeah.
A number of companies are offering that now.
That's a good point.
So I'm gonna add on you. So I'm him at 45.
I'm sorry.
I gotta stand up, we gotta. So I'm also, I work out, I do my exercises.
So
I try to eat
45,
healthy.
what's your calcium score?
So it's a 0. I got it done recently. I did the arterial study a couple of weeks ago on the YPO event down here that Prolong and some of you guys, other companies that are here were here. It was negative, but I run over 180 on the LDL, less than 30 on the HDL, and I run over 200 on the total. And I've been doing this since I've been younger than him.
Yes,
But I've never done that one. I've never done the MVP on my parents.
With the 180 and the 30.
And then negative genetics. I done the 23andMe and another one.
23andMe, I wouldn't go.
Well, I did the YPO one, which was
Get the cardiac.
Medgen, whatever, and they also told me negative ApoB3 and negative cardiovascular risk. So my cardiologist, who happens to be Juan Rivera from Hopkins, he's on Univision every day. He tells me I should be on something, but I'll beat him running. I run more than him. I don't know. I'm like looking at him going like, why? So I'm in the same conundrum.
Yeah. Well, before Christy answers this, let me just give you an anecdote. I had a very good friend. This guy, he played soccer, he ran, he was very physically fit. He was not obese, in fact, he was ideal weight. And at age 54, playing soccer, he dropped dead. And they did a post because he was out, and he had 3 vessel coronary disease. So be careful. Be
No,
careful. Don't be so
I've been getting the studies like the calcium scores, the carotid artery, but yeah, what do you suggest? Like I'm in the same boat 16 years later, but I haven't taken anything. I haven't tried fish oil or anything even regular. I'm just exercising. I thought exercise would work, but it's not working.
By the way, I just want you to know that the meter is running over here. There'll be a bill.
I had it.
Lifestyle is very, very important. It doesn't overcome, genetics completely, so certainly can help mitigate some risk, because even people with unfavorable genetics, lifestyle can lower the risk, but not obliviate it. So it's not only the magnitude of elevation, but it's the duration of elevation. So I like thinking of cholesterol years, so how many years you've been exposed to the LDL of 180. I check your lipoprotein A, because some of that elevated LDL may be unrecognized lipoprotein A. you're not supposed to order this for screening, but it's more for a workup for chest pain. But sometimes in younger individuals who had a 0 calcium score, but I'm still worried, a CTA looking for non-calcified plaque. We don't use CTA as a screening test, but so many patients, they have some chest pain or something, and so I ended up, a 0 calcium score is very reassuring to me as someone who's 70, 60, 70, that's got all those decades without calcified plaque. But someone in their 30s or 40s, especially with high LDL, I'm still worried that the lifetime risk is very, very high. And so I would favor treating. I mean, statins are effective, they're safe, they're cheap, they're generic, and really shifting the curve, because you're not really looking at your risk over the next 10 years. You're looking at your risk over decades. And so your health, now really, if your cardiovascular health now really influences your freedom from morbidity and mortality later in life. And so I would be thinking, the lifetime curves. We know from data from Framingham and other studies that even individuals with mildly or moderately elevated LDL, if they've been at that level for a sufficient number of years, they still have earlier onset of ASCVD compared to their counterparts that have lifetime low LDL. So it's good that your calcium score is 0 in your 40s, but you're still young, and so I would still be worried that other plaques. So you can look for carotid plaque, you can do a CTA. That's not the guidelines don't recommend.
We agree with your cardiologist, basically. but in regards to CTA, you have to ask around. Some people are doing these. You would not qualify for insurance reimbursement with it. The cost may be $3,000 to $5,000 to do a CTA, depending upon whatever they want to charge you, which can be who knows what. Now, there are a few places that will just let you pay out of pocket $500 to get a CTA with it. So you might just, you can get that at some point. Find a good place that's good and it's reputable.
The radiation dose is much lower now.
It's actually a good test. They don't need to charge that much, and it's something that I think in the future may end up being a nice screening test when we have a little bit more data. And also, but you still got to make sure the methodology for reading it, because when they're looking at the soft plaque, there's different software for analysis.
Okay, Christy, okay. We've got limited time. Yeah. Well, okay, he had his hand up and then you go.
Yeah, okay, so,
Oh,
here we go.
okay, let him go first, and then I'll come back to you. I'm sorry.
I got 5 world's experts here. So this is a 60-year-old Walmart executive